morning. I also want to take a moment to thank my fellow contributors on this study, Stuart Baker, Pam Marcus, John Clapp, and Barry Kramer, also at the National Cancer Institute or the National Institutes of Health. So to kind of put the rationale or study context why we wanted to do this, we've seen some increasing promotion of low-dose CT scans as a lung cancer screening tool to the public. This is mostly being done by individual hospitals, some advocacy organizations, kind of direct-to-consumer advertising, some of which are suggesting that the value of these scans can be to alleviate anxiety among smokers and current and former smokers. However, we don't have good evidence in hand right now that if you get screened, you'll actually see a reduction in lung cancer deaths, and potential burdens of screening have historically been underappreciated and underexamined. So we utilized study from the lung screening study. This was a feasibility or pilot trial for the ongoing larger national lung screening trial that's being sponsored by the National Cancer Institute. It's important to point out this is a distinct trial, but it sort of served as the foundation of the rationale to move ahead with the NLST. So it's a randomized controlled trial of chest X-ray and low-dose CT in lung cancer screening. We had 3,190 participants, so it's about 1,600 in each arm. They were 55 to 74 years of age, and they were current or former smokers. And we had 2 rounds of screening possible. So you had a baseline, a year 1 screen, and then we followed people up for a year after that. And we had a few goals we were trying to establish. We wanted to estimate the cumulative individual risk to a participant of receiving at least 1 false positive screening test. So if you wanted to participate in annual screening, what was your risk over time of receiving at least 1 false positive test? Then we also wanted to examine other potential burdens that might be associated with lung cancer screening, which would include rates of false positive prompted invasive diagnostic procedures. So here's the main results of our study. This shows you the cumulative probability of receiving at least 1 false positive screening test for an individual over time that wanted to participate in multi-year screening. You look along the x-axis, you see our screening test number, so 1 and 2, and that y-axis shows you the cumulative probability of having at least 1 false positive. You should note that scale only goes up to 50% for ease of viewing here. So you see that red line is actually for low-dose CT, and after 1 screen, your risk of having a false positive is 21%, and that rises to 33% after 2. And we've shown you chest X-ray here for comparison. That's 9 and 15% respectively. Now we switched gears a little bit, and this is no longer looking at cumulative probabilities, but rather the proportion of patients in the study that ended up undergoing various diagnostic procedures. So this is not a probability, but a proportion. And I'm going to focus on the CT arm for this purpose. So if you look at this, we started with imaging exams, and imaging exams repeated after the screening test would include things like a high-dose radiation CT or a PET scan, sometimes a thin-slice CT. And you can see that 61% of people that had a false positive test went on to have at least 1 more of these radiographic procedures done. Then we divided up all of the procedures that ended up being done on people into 3 basic categories. We had minimally invasive procedures, and that's like a bronchoscopy, so you would have a scope put down your trachea, and you can see 5% of people with a false positive result had that done to them. We had moderately invasive procedures, which would include things like a lung biopsy, a lymph node biopsy, or what's called a VATS, which is basically a laparoscopic surgery in the chest, and 4% of people with a false positive finding had that procedure done. And then we also looked at major surgical procedures, so that would be an open lung resection where you actually are going into the chest, or a thoracotomy. And that was almost 2%. 1.6% of our false positive participants had major surgery for what turned out to be a benign finding. And then finally we said, well, what was the rate of any procedure at all being done to you? That excludes imaging because we don't consider that an invasive procedure. And that was almost 7%. 6.6% of people with a false positive had that happen to them. So our conclusions from this study is that the risks of false positive lung cancer screening tests are substantial after just 2 annual exams. So again, that was 33%. We feel that the cumulative risk curve is a useful tool as a decision analysis discussion between practitioner and patient. It's a very easy to read sort of visual aid. And given the fact that we have seen such a high burden of false positives with low-dose CT lung cancer screening, we feel that careful investigation of the physical, psychological, and economic ramifications is warranted before continued promotion to the public. Thank you very much.